Well, hello. Thank you very much for joining us for what I know is going to be an absolutely fascinating discussion. It's going to be informative. Hopefully, it will be provocative. And if we absolutely get it right, there'll be a little gentle disagreement. So, we're going to use the AuToDeCRA study as our topic of conversation. And who better to discuss this study than my dear friends and absolute eminences in the field, Professor John Isaacs and Andrew Cope. John, Andy, warm welcome to the podcast.
Thanks for having us, Ian.
Always a pleasure, gentlemen. Always a pleasure. Well, look, let's get this discussion started. John, I'm maybe going to come to you first of all. What on earth is AuToDeCRA?
Thank you. Thanks, Ian. Well, AuToDeCRA is it's an ongoing program. It's actually been going on for about 15 years. It's our attempt in Newcastle at achieving antigen-specific therapeutic tolerance in patients with rheumatoid. So AuToDeCRA actually stands for autologous tolerogenic dendritic cells for rheumatoid arthritis.
Whoa. There's a lot in there for our practicing clinicians. So dendritic cell, quick definition.
Dendritic cell, I call them the generals of the immune system. They coordinate everything that happens in the immune system.
Okay, and the idea is that you are using dendritic cells as a therapy. You change their behavior somehow. Is that what's
so in everyday life, dendritic cells can do essentially one of two things. They either switch immune responses on, which is what happens when the body gets an infection, for example. But actually, a lot of the time, they go around the body switching immune responses off and preventing responses to self. So they're really important in preventing autoimmune disease. What we're doing in AuToDeCRA is generating the second type of dendritic cell, the down-regulatory dendritic cell from patients' blood, and then re-administering the cells in an effort to switch off rheumatoid arthritis.
So as so often in the immune system, there's a yin and a yang. Most things that are switched on will also create an autoregulatory response. And if I get this right, you're capitalizing on that ability to regulate. Is that a fair synthesis?
That's correct. That's correct.
Yeah. Okay. So, Andy, just coming to you now. So you've spent, goodness, a couple of years at least, young man that you are, thinking about autoimmunity in the wider context of rheumatoid arthritis. And again, just at that 35,000-foot view, Andy, a quick summary of why, what is the role of autoreactivity in rheumatoid and the current thinking, and why might changing autoreactivity be a good idea?
So I think the concept of autoreactivity in rheumatoid is an interesting one. And when I'm teaching medical students and juniors, I try and remind them that in fact rheumatoid is a sort of a chronic inflammatory syndrome with some very distinctive autoreactive features. And we recognize that autoreactivity by the presence of autoantibodies to post-translationally modified proteins and peptides. So these are citrullinated peptides, and we'll come back to that in the context of AuToDeCRA. But the biggest challenge we have is that those assays, anti-CCP, are recognizing distinct motifs which are probably present in multiple autoantigens. So the autoreactive response in RA, I would say, is promiscuous, it's permissive, and one of the biggest challenges we have specifically in the context of inducing immune tolerance is what the hell antigens do we target? And I think what is of particular interest about this study is that John is using not just one, but a bunch of different citrullinated peptides to induce that off signal in the hope that this will spread and affect other autoreactive processes that are going on both in the periphery systemically and we hope in the joint.
So Andy, just picking that up and maybe staying with you for a moment. You stopped short of saying the autoreactivity is the pivotal dominant driving part of the response. But can I just provoke you a little? How critical are those immune responses in the T cell or the B cell compartment that are recognizing post-translationally modified proteins, citrullation being the one that most of us are familiar with, although for our listeners, remember that you can have carbamylation, acetylation, possibly even other things that could be autoreactive targets. But I'm interested in your thoughts on where does this sit in the hierarchy of driving what we in the clinic are treating?
So I think there are two answers to that question. If you think of the natural history of RA, these autoreactive responses almost certainly occur before the disease starts. So let's be clear about that. And that's linked to the fact that we can measure autoantibodies years before the disease starts. We have very strong associations with immunologically relevant gene mutations, HLA-DRB1, PDPN22, among others, that we know are likely to have a profound effect on the signal input into a T cell, which makes it behave badly. In established disease, what's driving flares? It's going to be a combination of things. The T cell is up there, but the chronic inflammatory response, the cytokine, the chemokine response are key parts of that. And whether an acute flare arises as a consequence of new antigenic drive, I think is an attractive idea, but is actually quite difficult to prove because we just don't have the tools to actually measure that. But I think that is the sense that there is a significant antigenic drive. And so to be able to switch that off and to switch off the cells that are promoting that, antigens presented by these dendritic cells, and switching the DCs off so that the signal is regulatory or anti-inflammatory, I think is a key thing to study.
Now, you two gentlemen need to go easy on me. Remember, I've spent 20 years studying the innate immune response, particularly macrophage biology and its interaction with the stroma. So, and now you're telling me that actually the T cell compartment and or via its interactions with the B cells could be an upstream driver and potentially even the original sin, Andy, certainly in the pre-disease phase. But I guess the bet here, John, is that it also has a role in the established disease phase, which is, at least as I understand it, where AuToDeCRA is targeting patients at the moment, yeah?
Yeah, again, as Andy says, there's a number of possible models here, but in my head, I think the adaptive immune response is still driving events in established rheumatoid arthritis. I think it is definitely an interaction in my head between the innate and the adaptive response. It may be that the stroma in the joint is really important in determining what happens next. But for sure, if you haven't got autoreactive cells, and I think the disease can't propagate itself.
So I guess just from a clinician's perspective, this is almost immunological holy grail territory. What we're trying to do is we're trying to really precision treat, and this is different from personalized medicine. This is precision treat the pathogenesis of disease, which means we would move away from the broad spectrum immunomodulators that, frankly, by definition, comprise most of our therapeutics that target the innate immune response. Because we do need to remember that our medicines are exquisitely focused on a given cytokine. But the problem is the cytokines have such broad effects in the immune system. We're missing that real precision focus on the bit of the immune response that is most miscreant. So I guess what you could be offering us as clinicians is an intervention that in the long term could spare patients significant harm accrued by the breadth of immune modulation that we currently achieve with our medicines. Have I overstated that? I don't want to exaggerate the importance of the work, but it feels to me like that's the direction you're taking us.
I would agree. I think it is, Holy Grail is actually a good term for this. It is the Holy Grail. I would say switching off the immune response in general is a bit of a Holy Grail, but if we can do this in a precision way so that we just target the part of the immune system that we're pretty sure is driving things, then that should be a safe and ultimately effective therapy. But it is a Holy Grail. There's a lot, we've got quite a way to go.
Yeah, it's interesting, isn't it? And it's a cellular therapy. We take cells away from the patient. You change their condition by tolerizing them in the laboratory, and then they go back into the patient. Would be actually that's a really crude McInnes view of the world. It's at the level I can understand, but John, you could be, I think, maybe a little more sophisticated. I'd quite like to understand just a little bit about what are the practicalities of this study. What actually happens to a patient who comes in to AuToDeCRA trial program?
You described it perfectly, really. It's It's slightly involved for the patients, although the patients or the participants, we should call them, are pretty comfortable with the trial. So what happens is once they're screened and they're deemed eligible, which involves tissue typing, for example, we're looking for patients with a particular tissue type who definitely have autoantibodies. So in that sense, we're narrowing it down to a type of patient that we think will respond to this therapy. The first thing that happens, they undergo a procedure called leukapheresis, where they're uh, hitched up to an apparatus which takes blood from one arm, goes back in the other arm, but without white blood cells. So the white blood cells are taken out and they get their red blood cells back. That procedure can be as quick as an hour. It can take a little bit longer, depending on various technical factors. The patients go home after that, participants go home after that, and they reappear a week later. And during that week, the monocytes from their white blood cells, so the blood cells we call monocytes, are subjected to a differentiation process in an ultra clean lab we call the Good Manufacturing Process Laboratory. It's where stem cells are harvested, for example, for other procedures. But so it takes a week for these cells to be differentiated into what we call tolerogenic dendritic cells. It's a very robust process. It pretty much works every time. The patients then come back, as I say, a week later into our clinical research facility. In AuToDeCRA 2, their tolerogenic dendritic cells are then re-administered by one of several routes. They can either get them into a joint, into the dermis of their skin, or actually directly into a lymph node. And one of the things we're looking at in AuToDeCRA 2 is what would be the optimal route of administration for this sort of therapy. We think the cells have to get to lymph nodes to do the job of switching off the immune system, which is why lymph nodes is one of the routes.
And I guess, Andy, I guess that's one of the obvious opportunities, but also challenges here, which is geographically, how does this work? How widespread is the immunological sin? We talked about it. And do we need our tolerizing dendritic cells to go to all of the immune system, every lymph node? Or in theory, could we just go to one lymph node and use that node to trigger a new regulatory response or whatever? Any thoughts on that geography? Because for me, that's one of the beautiful things, John, that you've designed into the trial, is to actually think about whereabouts dendritic cells have to go. But just from a theoretical perspective, Andy, just what are your thoughts?
Well, guys, you will remember vividly when we were growing up, there were investigators looking at oral tolerance
Yeah.
and the amount of effort, energy, dollar put into trying to tease apart, A, whether it works and then how it works. I mean, we remember the work of Howard Weiner and then people, working in EAE and others. And, there was a hint that
Andy,
there
I
was
was at
something.
high school at the time. But
Yeah,
just for the record
actually,
here, I don't want any misunderstanding to enter into the literature. But
I wasn't sure you were even born then, but it was happy days. I mean, it was very interesting from an immunological standpoint. A lot of it done in mouse models, and then people started feeding people. Do you remember chicken soup with collagen in? I mean, it got slightly crazy. What I love about the design of John's study is exactly as you say. This is an amazing opportunity. We're fairly comfortable with safety. So the step we're at now is where is the action? And my bias is that I think the lymph node may be the place. And that speaks also to where we suspect the action is before the disease has actually even started. So if you imagine sort of resetting or retuning, as John I think likes to call it, um, an autoreactive response in the secondary lymphoid organs. The idea would be that this would then have an impact systemically. Putting the stuff in the joint is a good idea. I think John's already shown in AuToDeCRA 1 that doesn't induce flare. And the terrifying prospect of putting a dendritic cell loaded with peptide into a joint, I mean, you have to be pretty courageous to do that kind of stuff. John showed that it's not a problem. So that's super reassuring. And I think being able to compare both the impact of direct administration and lymph node, and then also dermal. I mean, a lot of effort's been gone into showing whether that works, and actually has been the favored route for many. So I think the design is on the button, and I think we have a good feel for what these immune signatures are like and how they could change, and I think that will give us an idea of how systemic this tolerogenic approach will be.
No, lovely synthesis. Thank you. So John, just it's a study that's ongoing. Can you tell us where you've got to and when we can expect to hear about the key results, the new learnings?
Yeah, well, the happy news is that we are fully recruited now. So our final patient was recruited last week and received their treatment.
Congratulations, wonderful.
So everybody has had their treatment. There's 20 patients in the I keep calling them patients, participants in the trial. 4 are controls and 16 got active therapy. One thing we haven't touched on, which I think is really important, is what are the outcomes in this sort of trial? And as you will know from things I've said in the past, I strongly believe that our routine outcome measures for rheumatoid trials like CRP, swollen joints, are not necessarily appropriate in this sort of study. So if these tolerogenic dendritic cells switch off rheumatoid, it may be a few months before the patients feel the benefit. And therefore, if we run a trial where we measure swollen joints or CRP, we may be destined to failure.
And John, just to interrupt, I want to connect that. I could not agree with you more. And I need to connect that remark with what we were talking about 5-10 minutes ago, which is the innate current targets, which are cytokines, JAK inhibitors, glucocorticoids for that matter. And to a large extent, those anti-inflammatory outcome measures were designed for anti-inflammatory drugs. They were never designed for the creation of long-term immunological tolerance and its consequences. So just particularly for clinical colleagues who are listening in here, that's a critical distinction. And it does mean that the expectations placed on tolerance-inducing trials, honestly, we need to be very circumspect. And the worry here is we throw babies in bathwaters out here. A standard change in a DAS, a CDAI over 12 weeks might miss a absolutely clinically relevant change in the autoreactive immune setting. And so, John, I really welcome your remarks. And it's something actually, in truth, I think all three of us have said publicly for quite some time. So your last patient's in, John. When can we expect to hear what happened?
So last patient, last visit will be September. And our primary outcome, if we thought that recruitment was a challenge, then I think the next step, which is trying to demonstrate positive effects, is also a challenge, because we're focusing on immune monitoring technologies. And what I mean by that is we are using techniques which will enable us, we hope, to identify the very rare autoreactive T cells, which are the cells that we hope our dendritic cells are modifying, and demonstrating that they change from before treatment to after treatment, whether that be in the blood or in the lymph nodes. We need to show that this treatment has had an effect on them. That's not the only thing we're looking at, but in our heads, that's the thing we need to be able to demonstrate to show the treatment's working.
And Andy, I will allow you a 30-second digression, because I'm a huge admirer of this incredible peptide scanning work that you've been doing, where you're actually looking at the kinds of peptides that the MHC class 2 molecules in the rheumatoid joint are presenting. And just brief recollection, the McInnes Guide to Simple Immunology, which is my level, these class 2 molecules present the peptide, they bind the peptide and show the peptide to the T cell. And Andy and his colleagues have done these extraordinary studies where you take the peptides off the class 2 molecules, so-called elution of peptide, and you actually then sequence the peptide and say, this is what's actually there. So Andy, just a couple of seconds on that, if you don't mind, because it feels terribly relevant given what John has just said about reprogramming T cells.
Yeah, so Ian, I think this speaks to my earlier comment about a sort of polyreactive uh, autoimmune response. We see peptides eluted off class 2 molecules from the joint, stimulating multiple T cells. Um, and so that makes our job even harder. Which one do you choose for this kind of therapy? And I think in the end, it will probably end up being a case where you just need to tickle enough T cells with enough peptide with the tolerating dendritic cells to be able to drive this immune deviational modulation. So John's selected 4 peptides from alpha-enolase, from SILP, from Vimentin, tenacin C. These are all citrulinated. And I think the advantage of having multiple peptides is that you're more likely to hit a bunch of different T cells and hence switch them up. So the nature of the antigen may not be critical in the same way that, for example, in type 1 or in thyroid autoimmunity or EAE, that it's much more restricted response.
I really love the convergence of the incredible science you've been doing, and that John and Kat Hilkins, I should say, up in Newcastle have been doing it. It's absolutely pioneering. Tickle T cell sounds like a dish from a Michelin star restaurant, Andy. So tickle T cell is something I'm going to look out for that and see if I can order some next time I'm treated to the local.
I think they have a tickle T cell restaurant in Barcelona, so we can hang out there next week.
During the EULAR Congress, yes.
Exactly.
Actually,
right.
We'll be working so hard, Andy, that we won't have time to go there in person, but we can possibly send delegates just to see if tickle T cell tastes as good as we think it might.
There you go.
Look, we're almost out of time, folks. So I just a couple of final things that I want to explore. First of all, John, whenever we design a trial, we've got to also understand that there are going to be limitations and caveats. You've already actually touched on a couple of those, but just to manage expectation out there, anything else you'd like to say about the limitations and the current it's still an early trial, isn't it?
It's still a very, very early trial. It's not specifically powered. It's a small number of patients. I mentioned the different routes that we're administering the cells, so it's just 4 patients in each group. As I hinted at, the real challenge is demonstrating that we've altered autoreactivity. I think if we can show that, then we're really winning. It's because that will then provide us with important biomarkers for the next study and the next study after that. I believe one of the reasons that this sort of treatment has not translated well. People were achieving tolerance in animal models 30 years ago, as you well know, even 40 years ago, and it's not translated. And I think it's because we've been measuring the wrong outcomes, as we've just discussed. So if we can robustly show that we are changing something in the autoreactive response as a consequence of this trial, it will tell us which route to go for next. It may be we need to administer the treatment 2 or 3 times, but once we've got something to measure, then we can really design those trials with a robust outcome, which we've
potentially even in the context of clinical remission state.
Absolutely. Yeah. So that's the excitement for us. We want to identify something which helps us to design the next step. So yes, it's quite a long way from clinical reality, but I think it's an important step if we show a positive outcome here.
Yeah, I think that reality in no way diminishes the importance of the work that's being done, by the way, but thank you for that qualification. Andy, let's imagine this worked. And we're optimistic, but it's a trial for a reason. What would this mean for rheumatology, in your view, for us as practicing clinical rheumatologists? Where could this fit in the armamentarium going forward?
So I think first up, this would be a milestone moment. I think the first time really where we're getting a sense that an antigen-specific therapy is actually modulating a chronic inflammatory disease. So that's the first thing. Understanding the signatures and being able to develop surrogate markers. John, you guys are doing a lot of work on this so that this could be translated in the clinical setting. So the monitoring is going to be important because in the end, the dosing interval, if you're going to require frequent dosing, is going to be determined by those signatures. And then you hinted at this. My sense is that using this treatment at a point where you see someone early, you get them into remission on standard DMARDs, and then you do the T cell tickle is one option. And then if those studies look encouraging, I would go one step further and think about the population that I'm particularly interested, the at-risk population, where there is clear evidence of autoreactivity and actually inducing immune tolerance before the disease has started. I mean, it's almost like vaccine therapy, and I think that would be the sort of down the line goal that we could be aiming for.
It's an incredibly exciting and enticing prospect, Andy. Thank you for sharing that. As I say, we're pretty much out of time here. I would, however, just love to get that famous, the takeaway. So, John, what's your key takeaway for those who've graced us with their presence and listening to this podcast? What one thing would you like our listeners to recall from the discussion?
I think I would say that this is an innovative therapy where targeting just the part of the immune system which we feel has gone awry in diseases like rheumatoid. And it's worth saying, if this is successful, then of course it will translate into other autoimmune diseases. And ultimately it would provide an incredibly safe but effective therapy. And as Andy said, if that can be turned into a vaccine for the at-risk group, then you are actually preventing rheumatoid in a very safe way.
Oh, fantastic. And Andy, same question to you. Your key takeaway here?
My key takeaway is watch this space. Antigen-induced tolerance, I think, is a prospect that we hope will be here to stay. And it's just understanding how we're going to translate it. Exciting times.
Yeah, I in the spirit of giving as well as taking, I have just a final takeaway on my own part. We are hearing a lot about cellular therapy in immune disease at the moment, but it's mainly the CAR-T, CD19, and other B-cell depleting agents. I think it's important to remember that this is a long way away from that. This is a subtlety, a nuancing, and really redirecting immunological tolerance, which is different from wiping out the entire B-cell compartment with the expectation, by the way, exciting as that is, that there might be some kind of immunological reset. So it's a very interesting time for us in the immune regulatory area as much as the immune modulatory inflammosuppressive area. So I think, just for our listeners, cellular therapy is going to be big business in the trial world over the next 2, 3, 5 years. And as Andy says, watch this space. Well,
and
look,
I think Ian, just to follow up on that, I think, you just talked about the CAR-T killing. What John's trying to do is to chill. So we're in the domain of chilling and not killing. And the opportunities for doing both, I think, is pretty cool for us lab rats to pontificate over, and also in the clinic.
And so maybe the tickle T cell becomes a pub somewhere in the balmy southern shires, Andy, and you go there to chill, not kill. I can feel the whole thing coming together in my mind, Andy. Thanks so much.
Retune rather than reset is what I would say.
Yeah. Retune and not reset. That is, by the way, not a criticism of other approaches.
No,
I wanted to highlight this is different from the other cell therapeutics that you're reading and hearing about at the moment, folks. And I think it's a nuanced approach, and it's properly exciting. So thank you. Look, Andy, John, thank you so much for your time today. Thank you for explaining this to us. I understand more than I did 20 minutes ago. And if you can get me to understand stuff, you are masters of your field. So, John, very best of luck with the study. We're really looking forward to hearing the results. Andy, also to you, you are one of the doyens in our field and understanding that core autoreactivity. So thank you both for sharing your thoughts. It's been a blast. And to all of you who've been listening and watching, do subscribe to the podcast on Spotify, iTunes, or other podcast media. I have to tell you, my kids always laugh when they hear me talking about podcast media, as if I knew what that was. Anyway, let us know what you think. You can also, of course, watch us on Immune-Mediated Inflammatory Disease Forum on YouTube. Now, I do know what that is. And finally, you can follow us, if you like, on X, LinkedIn, Facebook, to keep you absolutely up to date in all that's going on in the immune-mediated inflammatory disease area. It's one of the most exciting areas in the whole of medicine at the moment. We've got a lot of great new content coming in 2025 to tell you about why we're so excited. So look, thanks so much, Andy, John. It's been great to chat today. Hope you enjoyed the podcast, and we will see you on the forum sometime soon. Bye for now.
See you soon.
Bye.
Bye-bye. Bye.